So I'm Ernesto Gonzalez-Giraldo. I'm one of the pediatric epilepsy specialists here at UCSF. And I wanted to talk to you guys today about sudden unexpected death in epilepsy, or SUDEP, as you might have heard about it a little bit more. And what patients and families might need to know about SUDEP, which is one of those topics that oftentimes is hard to talk about in clinic, and that creates a lot of fear, understandably, and a lot of anxiety in patients. And I think it's one of those things that the more you know, the more you're aware of it, the more you're going to be able to sort of have a better discussion with your epileptologist. All right, so I have no disclosures. I'm just going to start off with a few facts about pediatric epilepsy, which I suspect a lot of people have talked about, but it affects 41 to 187 people out of every 100,000 people. So it's fairly, the number doesn't sound that high, but it's actually one of the most common neurological problems for children who have neurological problems. And something that is essentially what made me want to go into epilepsy is that around 30% of people who have epilepsy develop what we call medication refractory epilepsy, which means that they don't respond to medications as readily as other people do. So we know that around 2/3 of people will respond to 1 or 2 anti-seizure medications, but the chances of responding to a 3rd or a 4th or a 5th anti-seizure medication decrease with every iteration or every added medication. And so I really wanted to be able to make a difference for that 30%, which is what made me want to go into it. And at that point, we start thinking about other strategies for treating epilepsy, things like the ketogenic diet, epilepsy surgery, which is where we interact with Dr. Augusti, and neurostimulation. But another thing that I think I feel really passionate about is minimizing the frequency of SUDEP, of sudden unexplained death in epilepsy. What defines SUDEP? What is it? So it's a death that happens suddenly. It's unexpected. It can be witnessed or unwitnessed. So you don't have to have a witness to be able to call a death being caused by SUDEP. It should be non-traumatic. So somebody who has a seizure, falls, hits their head and has a brain bleed and then dies of the brain bleed didn't die of SUDEP. They died of that trauma. It is non-drowning. So same deal. If you have a seizure and you fall into a swimming pool and you drown, you died of drowning. You didn't drown of SUDEP, or you didn't die of SUDEP. It occurs in benign circumstances. So in circumstances that otherwise wouldn't have caused you to die. And there can be evidence or no evidence of seizures. So you don't always have, when you find somebody who has unfortunately passed away, you don't always have evidence of that they had a seizure right before they passed away, though sometimes you do. So if you find a laceration in the tongue, or the fact that they bit the inside of their cheek, or that they wet themselves, you might think that they were more likely to have had a seizure before passing away, but sometimes you don't find that, and even though you don't find that, you might, if you don't have any other causes for the death, you would be able to blame that death on SUDEP. It shouldn't be a death that happens as a result of status epilepticus, or a really long seizure that's difficult to control, that we think of as sort of a different cause of death. And though we don't do this for everybody, in order for us to sort of be very definitive about the fact that somebody died of SUDEP, you should have a post-mortem examination or an autopsy that doesn't reveal any other cause for the death. How common is SUDEP? Thankfully, it's not very common. So every year, around 1 of every 1,000 adults with epilepsy dies of SUDEP, and around 1 of every 4,000 children who have epilepsy dies of SUDEP, which, even though the numbers aren't that high, every death is really meaningful for that patient, for that family. And so we think about it really, really seriously, and we want to make sure that we're doing everything in our power to decrease the chances of that death happening from SUDEP. And I think this is sort of really what I wanted to talk about. What are things that might put you at risk for dying of SUDEP? It turns out that generalized tonic-clonic seizures, what other people might describe as grand mal seizures or convulsive seizures, is one of the main risk factors for somebody dying of SUDEP. So if somebody has more than three or more generalized tonic-clonic seizures per year, their chances of dying of SUDEP are much higher than in somebody who doesn't have convulsive seizures. That increases your odds of dying of SUDEP by around 15 times. Any generalized tonic-clonic seizures, though, so you don't have to have 3, but any tonic-clonic seizures can increase your risk of dying of SUDEP. Other things that have been shown to be associated with SUDEP include failure to add an additional anti-epileptic medication when patients become refractory. So even though we know that once you become medication refractory or medication resistant, the chances of an additional medication might not lead you to seizure freedom, they often sort of can decrease the frequency of seizures or the frequency of convulsions enough that they can modify your risk of having SUDEP. Not being seizure free for 1 to 5 years have been associated with an increased risk of SUDEP. Intellectual disability has been associated with an increased risk of SUDEP, and we think about that as both because people who have intellectual disability tend to have more severe forms of epilepsy, and also especially in the adult population, people who have intellectual disability oftentimes are less likely to have social so people around them that are monitoring them all the time, and so if they have a seizure, they could have seizure on their own. Epilepsy beginning at an early age is also a risk factor. Having epilepsy for a long time can be a risk factor. Nocturnal seizures is one that I often sort of think about when I'm counseling families. And then this one is curious. Some studies have shown that people who are on more than 3 anti-seizure medications at the same time can have a higher risk of SUDEP. And I think that that's often a fact that's a little bit misunderstood. I think a lot of people who I have spoken with who are on 3 medications and they're not doing well, and we're talking about adding a 4th medication, sometimes people will bring up this fact that having more than 3 anti-seizure medications is a risk factor for SUDEP. And I think it's rather than thinking about it as sort of the fact that more medications put you at risk for SUDEP, it's more the fact that somebody who needs 4 medications to have some degree of control of their epilepsy tends to have a very aggressive form of their epilepsy. And so it's the fact that they have an aggressive epilepsy that really puts them at risk of SUDEP, not necessarily the fact that you have 4 medications. So even though in general you want to minimize the number of medications as much as possible in order to minimize side effects, I encourage you guys not to be afraid of sort of adding a 4th medication. Usually we do that transiently. Usually we don't do that in the long term unless truly necessary. But I wouldn't be afraid of adding a 4th medication just in terms of the risk of SUDEP, because it doesn't really make sense for just the number of medications to put you at risk of SUDEP. And those people that require a lot of medications tend to have more aggressive or more significant seizures. And so those are the people that it's likely the severity of their epilepsy that puts them at risk for having seizures. But again, the main things that I want you to draw from this slide is that tonic-clonic seizures or convulsive seizures or grand mal seizures are a risk factor. That the more grand mal seizures somebody has, the more likely you are to have, or the higher the risk you have of SUDEP. And that the fewer seizures you have in general, the less your risk is going to have. So one of the take-home points here is that we should be aiming for as few seizures as possible, and that often it involves a combination of medications and dietary therapies and epilepsy surgery and neurostimulation in order to minimize seizures as much as possible. There's only been a couple of things that have been shown to sort of in the evidence really decrease the risk of SUDEP, and it's primarily focused on nocturnal supervision. So people who have somebody sleep in the same bedroom as they do, or who have nocturnal supervision, have a decreased risk of SUDEP than people who don't. And then their use of nocturnal listening devices. So this is sort of another another word for a baby monitor, or something that allows somebody to hear the noises that are happening in the bedroom of the person who has epilepsy, that has been shown to decrease the risk of SUDEP. And presumably that's because if somebody is either in the bedroom with somebody who has epilepsy, or is able to hear what's going on in the bedroom of somebody who has epilepsy, if there's a seizure that happens, you're going to be able to figure out that a seizure happened. You're going to be able to go make sure that the person isn't facing down into the pillow. You're going to make sure that the person is recovering from their seizures as well as possible. And if they're not, that person is going to be able to go get help. I suspect that with more research and as more time goes on, the list of these risk reduction strategies is going to increase, and there's a few things that I think are coming in the pipeline that are really exciting. So for example, vagus nerve stimulator. There's a thought that in the next few years there's going to be a vagus nerve stimulator that is able to tell when you have a seizure when you're facing down, and based on changes in heart rate and things like that. But if the VNS senses that you had a seizure while you were facing down, it's going to be able to send a message to a designated person, and so that person can go check on you. And the reason for that is that if you have a seizure and you are postictal and you're facing down into the pillow, you might be at a higher risk of smothering yourself or not being able to breathe while you're still postictal and not really able to sort of get yourself out of that situation. And then the more we understand SUDEP, the more we research SUDEP, the more we're going to be able to see, to know about other risk factors and other ways that we can prevent it. There's a few mitigation strategies that have been proposed for minimizing the risk of SUDEP. And many of them are surrounded or surround sort of your knowledge of SUDEP and you being aware of the risks of SUDEP, that or a person who has epilepsy and the family of somebody who has epilepsy being aware of the risk for SUDEP that patient or that loved one has. So being aware that SUDEP exists is really important. And knowing what risk factors somebody has, either your loved one or yourself has, in terms of what your own risk factor is and what your own risk of SUDEP might be. If you know what your seizure triggers are. So for example, if you know that whenever you're sick, you tend to have more seizures, or whenever you are sleep deprived, you tend to have more seizures. It's important to avoid those seizure triggers, or if it's unavoidable, for example, with illness, we can't always avoid being sick. But if you know that you tend to have more seizures or more convulsions around the times that you're sick, would be important times to surround yourself or surround that person who has epilepsy with people who are going to be able to monitor them and watch them. Because if they have a seizure and they're not sort of recovering from that seizure as well as they usually do, then you're going to be able to seek help appropriately and potentially save that person's life. Attending regular appointments with your healthcare team or with your epileptologist or your neurologist is also really important. Making sure that your neurologist is aware of how many seizures you're having and how and whether you're having side effects to your medications and what those seizures look like, and how well controlled your epilepsy can be really important. So making sure that you have a good medical home in terms of your epilepsy care can be really, really meaningful. Not skipping your medications, and that sounds obvious. If you skip your medications, you're going to be more likely to have more seizures and more convulsions and be at a higher risk of SUDEP. And this one's, I think, one that is really important to know about. So if you're with your loved one who just had a seizure and they're not moving, or they're not acting totally normally after the seizure, which is common, it's important to not leave them alone, and to if it's been a few seconds since they've not moved or they're not acting totally normally, providing a fair amount of stimulation. So changing the position, if they're facing down, making sure that that they are on their back, If they if their breathing sounds funny, or if they sound like they're obstructing, like they're snoring, or their breathing sounds really funny, sort of making sure that their airway is clear, that they didn't swallow anything, that they weren't eating anything before. And just stimulating them, sort of rubbing their body and providing them stimulation can oftentimes lead to people coming out of their post-ictal period a little bit sooner, and can decrease the chances of death in that situation. And if they're not responding, and if they're not sort of having that usual recovery, everybody has a post-ictal period after they have a convulsion, but and that post-ictal period can look really different for different people. So I hesitate to tell you exactly what somebody should look like after they have a seizure. But if they're not looking the way that they usually look after they have a seizure, if they are more sleepy, not breathing, turning blue, may have any changes that make you really nervous, never hesitate to call 911. That's what 911 is there for. That's and getting help there is going to be able to potentially save your loved one's life. So these are the things that you can do sort of as a loved one or as somebody who has epilepsy. And then the other things are more sort of combination strategies or things that you can do with your epileptologist or your neurologist. You should be aiming for zero seizures if possible. Many people can't achieve that. Many people, for many people, sort of that zero goal is not possible. But you should at least be thinking about what other strategies you could be using in order to achieve fewer seizures. Whether there's any medications that you haven't tried that might be that may decrease the frequency of your seizures, and whether there's anything else that you can do to get as close to zero as possible. If you're still having seizures, adding in additional medications, as I said before, can really make a significant difference in your SUDEP risk, even though you don't necessarily become seizure free. So even though the chances of becoming totally seizure free with medications may go down, trying different medications can be really meaningful in terms of the frequency of seizures, the severity of seizures, and overall your SUDEP risk. Always, if you're still having seizures, you should be talking to your epileptologist about other strategies for trying to control your epilepsy. So I've talked a little bit about this, and essentially this whole day has been very heavily involving some of these things. So think about, make sure that you're working toward figuring out whether you might be an epilepsy surgery candidate if you have focal epilepsy. And if you're not a resective epilepsy surgery candidate, are there any other strategies that you could be using? So could you be on the ketogenic diet? Could you be on the modified Atkins diet? Could you have VNS or RNS or DBS in order to improve your seizure frequency and decrease your risk of SUDEP? And then, like I mentioned, sort of if your loved one or you yourself who have epilepsy sleeps in a room by yourself, consider getting a nocturnal listening device or a baby monitor that somebody who is near you can listen in on. And again, that's because most of the time convulsions, which are the highest risk for SUDEP, are noisy things, and so you can usually hear a convulsion happening and go check on somebody who just had a convulsion and make sure that again they are recovering from their seizure as well as they usually do. And if you can have nocturnal supervision, whether that is sharing a bedroom with somebody, whether that is having a sibling sleep with that person, having somebody who knows that the person has seizures, who is in that bedroom with them at night, can really make a big difference in terms of their SUDEP risk. So this was a quick discussion. I really wanted to give you guys a chance to ask me questions, but my main take-home points are aim for zero seizures if possible. If you're still having seizures, consider adding another medication or another strategy for improving your seizure frequency. And then really think about getting a baby monitor or a nocturnal listening device for somebody who's sleeping on their own. There's a few resources that I wanted to make sure that you guys were aware of. So your epilepsy team should be a big resource from this perspective. Never hesitate to ask about SUDEP. I think it's it's especially in the early meetings, it's hard to as an epileptologist or as a neurologist to bring up SUDEP because you're still trying to create a doctor-patient relationship. It's something that certainly I've been trying to work on myself, but I actually really love it when patients bring it up themselves, because it tells me that they're thinking about it. It tells me that they're ready to talk about it. And it tells me that it's that it's something that I can address without sort of fearing making them really terrified and having them run away from our practice. The Epilepsy Foundation, so either your local Epilepsy Foundation or the National Epilepsy Foundation, has a lot of resources, and specifically they have a subcategory or a sub or a sort of a smaller unit within the Epilepsy Foundation that's called the SUDEP Institute, that has a lot of resources in terms of education, in terms of advocacy, and in terms of research that can be really meaningful for patients. These are some of the papers that I use to sort of give you guys the data that I presented, but I really think that this is the main thing that I want you guys to take home, is sort of aiming for zero seizures if possible, if still having seizures, considering adding another medication, not being afraid of adding another medication, and then nocturnal supervision can be pretty huge. Do you guys have any questions? So I'm gonna try to bring up the chat because as I mentioned, it's hard to know if there are any questions there. Are oxygen monitors or other non-video audio monitors recommended? So there's not been a lot of data that supports use of oxygen monitors for it. I tend to my experience, or at least the experience that I've had with my patients who use oxygen monitors, is that it leads to both more anxiety on behalf of the parents, because there tends to be a lot of false positives. Our oxygen in general can go down to some degree when we're asleep, but more significantly, the little thing that hooks up to your finger sort of falls off because you're moving in your sleep, and so it'll alarm, and then alarm 3 times a night for every night for 3 months, and so the parent will sort of develop this alarm fatigue, and then when in the episode that where there was actually a seizure, you might think, oh gosh, this is just another false positive, and go in and fail to go in. So I think that the things that have more data tend to be the sound or video listening devices or monitoring devices. So I generally don't recommend oxygen monitors, but that's a really great question. And I suspect that as we get better at oxygen monitoring, that might improve. Somebody, I think, messaged me directly, but they asked if the genetics play a role in SUDEP, and that's definitely true. So there's some, it tends to be related to how severe the epilepsy that's associated with a genetic diagnosis is. I suspect that there's probably more to that, and we just don't understand the genetics of SUDEP particularly well. I suspect that in the next decade we'll understand that better, but we certainly know that there's some genetic diagnoses that increase your risk factor, that increase your risk for SUDEP pretty significantly. So for example, Dravet syndrome has a much higher rate of SUDEP than other epilepsies. And whether that is because the sodium channel is also expressed in the heart and it can change your heart connectivity, I think is truly unknown. What we do know, however, is that the more severe epilepsies tend to have a higher risk of SUDEP. Somebody else asked, are there pillows that are recommended for or not recommended for epilepsy patients? There aren't any sort of specific products that I know of that are recommended for people who have SUDEP. In general, I think that a lot of sort of the same recommendations that we give for SIDS are helpful for patients who have epilepsy in terms of preventing SUDEP. So the less you can have the less sort of stuff you can have around you while you're asleep, so that if you have a seizure and you sort of have a stuffed animal or a big pillow, and you might, if you have a seizure, you might end up with your face sort of right on that pillow or right on that on that stuffed animal, and then it can suffocate you. So the less stuff you can have around your bed, the better. And then it tends to be better for people to sleep on their back. That's a lot harder to do for older people than it is for babies, right? Babies can't around the time that they have a risk of SIDS, can't really flip themselves around. And so that's why that back to sleep really strategy really works for people, for babies and preventing SIDS. A lot of people can't sleep on their, like, physically don't have an easy time sleeping on their back. But in general, if you can sleep on your back, if you can sort of minimize the amount of stuff that's around your face, I think that all of those would prevent sort of you from suffocating if you have a seizure. Another question that was asked was, do Lennox-Gastaut patients or Lennox-Gastaut syndrome patients have a higher risk of SUDEP? And I think that the answer to that is yes. Similar to Dravet syndrome, patients who have Lennox-Gastaut syndrome tend to be more difficult to control. So their seizures tend to be tend to not respond to anti-seizure medications as well as people who have other types of epilepsy, and so they definitely have an increased risk of SUDEP, likely because they're still having seizures, not so much because there's something unique to the diagnosis of Lennox-Gastaut syndrome, but more because they are having seizures. So if you have an LGS patient that's not having a lot of seizures or is well controlled, I would worry less about that patient than somebody who has, say, focal epilepsy who's still having seizures. You guys have any other questions? So I know this is a sort of a really emotional topic and really scary topic, for understandably, for all of our patients who have epilepsy and their loved ones. I just really encourage you not to be afraid of talking about it with your doctors. I think, you know, being aware of that it exists, being aware of what your risk factors are, can be really meaningful in terms of you taking the necessary steps to improving that risk. Great. So I'm happy to hang around for a couple of minutes just in case you guys have any questions. Feel free to oh, if we haven't seen tonic-clonic as a seizure type in our child, would that still be something we look for? She has absence seizures. So I suspect, as I understand that question, you're asking me if absence seizures, like if somebody who doesn't have tonic-clonic seizures still is at risk for SUDEP. And the real answer is anybody who has epilepsy can have SUDEP. But the seizure type that gives you the highest risk increase for SUDEP is the tonic-clonic seizure. So certainly if you haven't seen any tonic-clonic seizures, I would feel better about your risk of SUDEP. But it isn't zero. And so I would still sort of make sure that you're aiming for having as tight of control of your seizures as possible. If you're still having seizures, even if those seizures are absences, which admittedly are much less risky in terms of SUDEP than other types of seizures, I would still work toward getting those as controlled as possible. Great. Well, it's been lovely chatting with you guys. I had a chance to listen to a few of the other talks and lots of really great talks today. I'm glad you guys are were here to listen to what we had to say. And I wish you the best of luck. I hope you guys are in real. I know that if you're in the hands of one of our epileptologists, you're in really great hands, and I hope that you guys continue. Really, if you're yeah, I just wish you the best of luck. Can a nocturnal seizure not get picked up on an EEG? So most seizure, like if you have an EEG while you have a seizure, most of the time you see some changes on the EEG. So there's nothing about a nocturnal seizure that would make me think that EEG is less likely to capture the seizure. Certainly, there are some seizures that either come from a place that is very deep in the brain, or that are very, very, like very, very focal, meaning they're only involving a very, very teeny part of your brain, where it wouldn't be sort of involving enough brain that you can see it on a scalp EEG. If that's the case, you might not see as many changes on the EEG as you might see with other seizure types. But honestly, that's one of the reasons why when we do seizure or EEG monitoring, we also have video monitoring, and it's that seizures in general are very stereotyped. So if I'm seeing an event, and gosh, every time I see it on the video, it looks exactly the same, even though I'm not seeing a lot on the EEG, I would really worry about that being a seizure. But there's nothing about a nocturnal seizure itself that can make it less likely to get picked up on an EEG. The other question was, does Jevon syndrome have a high risk of SUDEP? So Jevon syndrome is this generalized epilepsy that has a few seizure types. So usually you have absences, you also have eyelid myoclonias, which is where your eyes flicker. And you can also have tonic-clonic seizures. It can be pretty difficult to control. So it's in many people who have Jevon syndrome have ongoing seizures. For those people who are still having seizures, I think the risk is there. But I would go back to those risk factors. If you're not having tonic-clonic seizures, I think your risk is lower. If you're not having nocturnal seizure, your risk is lower. If you are having those, then your risk might be higher. If you're still having seizures, I would encourage you to talk to your epileptologist about what you could do about that. Our daughter was given rescue meds for subclinical seizures when she was on video EEG. How do I know these are not happening at home? So that's an incredible question. I think that we don't truly understand how subclinical seizure, like what the risk of SUDEP is with subclinical seizures. In general, the only way of figuring out whether or not you have subclinical seizures is by doing video EEG. And so depending on when those seizures were captured, sometimes we do video EEG monitoring when people are when we're doing a surgical evaluation. So we've taken them off of medications, and so we can see a lot more. Like in that situation, we can see a lot more subclinical seizures and clinical seizures than you would see otherwise. I think the only way of really figuring out whether subclinical seizures are happening would be to sort of do a video EEG while on medication, sort of in a situation like what you have at home. In terms of whether those seizures or subclinical seizures increase your risk of SUDEP, I think the answer is really we don't know.